Pharmacokinetics. When students have completed this content, they should be able to compare the differences between pharmacokinetics and pharmacodynamics, delineate the common routes of medication administration in sports medicine, describe the concepts of bioavailability and the quantity of drugs that reach the systemic circulation, trace the path of an oral medication from administration to excretion, including the first pass mechanism, and reinforce the need for thorough medication review for all injury or illness conditions that are being treated pharmacologically. Pharmacotherapeutics. It is important to understand the different methods of delivering drugs to the tissues of the body and how these methods affect how the drug is metabolized and utilized by the body. Pharmacotherapeutics is a field of study including how drugs are used to treat, prevent, and diagnose disease and illness. There are two subcomponents, pharmacokinetics and pharmacodynamics. Pharmacokinetics is how the body assimilates, incorporates, and eliminates a drug. This also includes the rate at which the drug begins to take effect, the duration of the drug effect, and the factors that impact the rate of change in concentrations of drugs at a site of action. This also includes the impact of the drug on the body. The focus of pharmacokinetics is on the rate and the extent to which the drug is absorbed into the bloodstream, distributed throughout the body, metabolized, and finally excreted. This process affects the magnitude and duration of the biological responses, the therapeutic or desirable effect, as well as the adverse or undesirable effects. Pharmacodynamics is how a drug affects the body. This includes the mechanism of action of drugs. Some drugs, for example, combine with an enzyme to inhibit enzymatic processes, whereas others combine with the receptors to either initiate or inhibit a particular effect. Pharmacodynamics studies the impacts of drugs on the body. The primary focus of pharmacodynamics is on the molecular mechanism by which drugs exert their therapeutic and adverse effects. The molecular mechanism is encompassed at the biochemical mechanism and physiological response level. As the dose changes, the degree and the type of response may also change as the drug occupies more of the receptors in a particular tissue and additional receptors in other tissues. Clinical pharmacokinetics is the discipline that describes the absorption, distribution. Clinical pharmacokinetics is the discipline that describes the absorption, distribution, metabolism, and elimination of a drug, often abbreviated as ADME, in patients requiring drug therapy. A successful drug must be able to cross the physiological barriers. After that, Step 1, the absorption. This allows for the drugs to pass through these barriers. Then Step 2, distribution. By the body's systems as blood and lymphatic vessels, the drug's ability to act on its target tissue is also limited by several processes within the patient. Step 3 is metabolism, how the body transforms the drug through enzymatic degradation. And finally, Step 4, excretion. The drug is finally eliminated from the body, primarily by the kidneys and in the feces. This is a schematic diagram of the relationship between pharmacokinetics and the pharmacodynamics of a drug. Pharmacokinetics involves the absorption, distribution, metabolism, and elimination, whereas pharmacodynamics includes the efficacy, toxicity, receptor binding, signal transduction, and physiological effects of the drug. Biopharmaceuticals is the study of the physical and chemical properties of a drug and their proper dosage as related to the onset, duration, and intensity of the drug action. The first step of the pharmacokinetic process is for the drug to be dissolved in the bodily fluids to be absorbed through the biological membranes. For the drug to be dissolved, it must be liberated or released from its dosage form. A drug in a solid state must dissolve into its molecular form in the bodily fluids. Once a drug molecule has been liberated from its dosage form, it begins its journey to the drug receptor target. For most drug products, the active ingredient is dispersed within its formulation, either in its molecular form or as solid particles. The ability for a drug to be liberated or dissolved in body fluids depends on the dosage form, the solubility of the active ingredient, and the intended site of action. The dosage forms of drugs include the familiar tablets, capsules, and suspensions, as well as many other forms of drug forms. Drugs that are administered as aqueous solutions are ready to be absorbed into body fluids. Several examples include a drug administered in an oily or fat base and dissolve. A drug in an aqueous suspension must dissolve into suspended crystals in the body fluid. A drug in a compressed tablet must dissolve in a process of tablet disintegration, which fully exposes the drug crystals to the gastrointestinal fluids for dissolution. Some other examples of drug dosage forms include tablets or crystals in a compressed powder, capsules or powdered filled that are crystals in a non-compressed powder, capsules or liquid filled. These are molecules or crystals in vegetable oil. A suppository. These are crystals in waxy or a water-miscible base. And solutions, which are molecules dissolved in fluids. Other examples of drug dosage forms include suspensions. These are crystals in lattice matrix that are held in aqueous or non-aqueous fluids. Ointments are crystals or molecules in a semi-solid oily base. Creams are crystals or molecules in a water-miscible semi-solid cream base. Gels are crystals or molecules in a water-miscible semi-solid gel base. And aerosols are crystals or molecules suspended in a gas, liquid, or semi-solid. In pharmacokinetics, absorption is the movement of a drug molecule from the site of administration to the bloodstream. The rate and extent of drug absorption of each of these processes will differ. The step with which the slowest rate is the rate-limiting step, which ultimately dictates how quickly a drug enters the bloodstream. In general, the rate of dissolution or the rate of absorption is the rate-limiting step. The rate of the drug absorbed into the body depends on these processes, including the dosage forms, the solubility of the drug, the route of administration, and the plasma drug concentration, as well as the mechanism of absorption. The dosage form determines how the drug is liberated in the body fluids. The solubility is the formation and physiochemical properties that determine how the drug dissolves in the body fluid. The route of administration determines how the drug is administered and what barriers it must cross to be absorbed. The plasma drug concentration is how much of the drug is available for the therapeutic effects. This is dependent upon the first-pass metabolism and bioavailability. And lastly, the mechanism of absorption. This is the transport of the drug molecules across the cell membranes. The mechanism of drug absorption. Absorption involves the way a drug enters the body, passes into the circulation, and then enters into the cell. Absorption of drugs is based on many factors, such as the size of the drug molecules and the availability of the transport membrane carrier protein for a specific drug. In passive transport processes, drugs move into cells down their concentration gradients, typically from high regions of concentration into a region of lower concentration. Some drugs are actively transferred into and out of cells with the aid of drug transporters or membrane-bound proteins. The mechanism of drug absorptions include the following: either passive diffusion, facilitated diffusion, paracellular transport, or active transport. Paracellular transport occurs when the drug diffuses between cells, which is the typical way that drugs pass through tissues. In passive diffusion, the drug passes through the cell membrane lipid bilayers. This is the most common way that drugs cross biological membranes. It favors drugs that are lipophilic. Facilitated diffusion. The drug is passively moved with its concentration gradient. And finally, active transport. The drug is actively moved against its concentration gradient. This requires energy in the form of adenosine triphosphate, also known as ATP. This image illustrates the variety of ways that drugs are transported across cellular barriers in their passage through the body. This includes diffusion, facilitated diffusion, paracellular transport, passive transport, and active transport. The blood-brain barrier. The central nervous system presents special challenges to pharmacological therapy. Unlike most other anatomical regions, the central nervous system is particularly well insulated from foreign substances. However, this also includes medications. The blood-brain barrier uses specialized tight junctions to prevent the passive diffusion of most drugs from the systemic system to the cerebral circulation. Therefore, drugs designed to act in the central nervous system must either be sufficiently small and hydrophobic to transverse biological membranes easily, or use existing transport proteins in the blood-brain barrier to penetrate the central nervous structures. Hydrophilic drugs that are unable to target facilitated or active transport proteins in the blood-brain barrier cannot penetrate the central nervous system. After a drug is dissolved in body fluid, the molecules must pass through membrane barriers to be transferred to the target location. For most drug routes, the transporting fluid is the blood. Drugs that are injected through intramuscular and subcutaneous routes enter the bloodstream directly through capillaries and the lymphatic system. Drugs administered to the mucosal sites of the lungs, nasal cavity, mouth, vagina, and rectum must cross varying types of epithelia. For drugs administered through the enteral administration, also known as the oral route, absorption primarily occurs through a single layer of cells that line the stomach and the upper small intestine, also known as the duodenum and the jejunum. Absorption through the upper small intestine is usually far greater than through the stomach, primarily because the small intestine has a larger surface area, and the pH is generally better suited for absorption. There are advantages and disadvantages for enteral drug administration that will be further discussed as we move through this course. The first pass metabolism. Drugs that are administered by the enteral route are metabolized before they reach the systemic circulation. As the drug is absorbed through the gastrointestinal tract, it enters the hepatic portal circulation and is metabolized in the liver before entering the systemic circulation. This process is referred to as the first pass metabolism or the first pass effect. Drugs with high first pass metabolism are administered in doses sufficient to ensure that enough active drug reaches the desired site of activation. The stomach has a relatively large epithelial surface, but its thick mucus layer and short transit time limit absorption. Because most absorption occurs in the small intestine, gastric emptying is often the rate-limiting step. Food, especially fatty food, slows gastric emptying. This explains why taking some drugs on an empty stomach speeds absorption. After traversing the gastrointestinal epithelium, drugs are carried by a portal system down to the liver before entering the systemic circulation. The portal circulation protects the body from the systemic effects of the ingested toxins by delivering these substances to the liver for detoxification, potentially complicating drug delivery. In this process, liver enzymes may inactivate a fraction of the ingested drug. Bioavailability is the proportion or percentage or fraction of the drug administered and the quantity of the drug that reaches the systemic circulation. Bioavailability depends on the route by which the drug is administered, the chemical form of the drug, and the patient-specific factors such as the gastrointestinal mobility and the hepatic function of the individual. An intravenous drug that is administered directly into the systemic circulation is 100% bioavailable. The drug is then distributed to other body compartments and eliminated or excreted. In contrast, other routes of administration, for example, oral, subcutaneous, or intramuscular, demonstrate slower entry of the drug into the systemic circulation and may have a much lower bioavailability. Bioavailability and the area under the curve after administration of a single dose of a hypothetical drug administered by oral, subcutaneous, intramuscular, and intravenous routes is demonstrated on this slide. Plasma concentrations. Drug absorption is necessary to establish adequate levels of the drug in the plasma. Plasma drug concentration is determined by a two-rate process. 1. The rate at which the drug appears in the plasma, and 2. The rate at which the drug is eliminated from the plasma. The drug must also reach its target receptors in concentrations sufficient to have the desired therapeutic effect on the physiological process. The concentration of a drug in the plasma is typically used to define and monitor therapeutic drug levels, since the effect of the drug in the target tissues often correlates well with the plasma drug concentration. These pictures indicate the typical plasma level curve after an IV bolus and an oral drug administration. On the left is the plasma level after administration of the IV bolus dose, and on the right, the plasma level after an oral dose of a drug product. Drug distribution. Following absorption or systemic administration into the bloodstream, a drug is distributed throughout the bloodstream to interstitial and intracellular fluids. Initially, the liver, kidneys, brain, and other well-perfused organs receive most of the drug. Delivery to the muscles, most viscera, skin, and fat is slower. Thus, distribution of the drug is determined by its movement between the blood, the vascular compartment, and the interstitial fluid that surrounds the cell of the target tissue. A drug's entry into the systemic circulation and distribution to its target cell or tissues are influenced by several factors. The physiochemical properties of the drug, such as the size, charge, and the lipophilicity, the cardiac output and blood flow between the compartments of the body, the binding of the drug to proteins in the plasma and target tissues, the capillary permeability and the tissue volume, and the concentration of the drug between the central compartment or plasma and the peripheral compartment, the extravascular cells, and the tissues. The drug's movements through the body compartments. The volume of distribution is an important pharmacokinetic factor influencing the distribution of the drug in the body. The volume of distribution is the concentration of the drug in the peripheral tissues compared to the concentration in the plasma within the central component. Distribution of a drug to well-perfused tissues such as the heart, liver, kidneys, and brain is rapid, assuming that the drug is distributed in the plasma or the central compartment in equilibrium with the drug that is distributed. Drug distribution to poorly perfused tissues such as the bone, muscle, and fat in the peripheral compartment is much slower, and distribution equilibrium may not be reached for some time after drug administration. Drug concentration in poorly perfused peripheral compartments continues to increase for some time, despite declining plasma concentrations. Once equilibrium is reached, plasma and tissue concentrations of free drugs are considered equal and decline over time in a parallel manner. The concerns with prophylactic hyperhydration. The head athletic trainers from 27 teams in the National Football League, also known as the NFL, acknowledged having given a pre-game IV infusion of 1.5 liters of saline to select players. The intent was to minimize the risk of muscle cramps, although some players admitted a psychological dependence to receiving the IV fluid. Critics noted that pre-game IV fluid administration may not be medically indicated and that oral prehydration may be as effective as the IV practice and much less risky. NFL athletic trainers acknowledged the occurrence of adverse events secondary to IV fluid administration, such as superficial venous thrombosis. Pre-event IV fluid administration is banned by the World Anti-Doping Agency, also known as WADA. as a performance-enhancing practice during the international competition unless it is medically indicated. However, some literature critical of the NFL approach acknowledge the presence of limits and flaws in the research design. Drug metabolism. Metabolism is the process of which drugs are broken down into smaller usable parts through a series of complex chemical reactions, or biotransformation, until it's chemically inactive. Several organs are capable of metabolizing drugs to some extent using enzymatic reactions. The kidneys, gastrointestinal tract, lungs, skin, and other organs contribute to systemic drug metabolism. However, the liver contains the greatest diversity and quantity of metabolic enzymes, and the majority of drug metabolism occurs there. The most common metabolic pathway is the microsomal cytochrome P450 CYP enzyme system, which mediates many oxidative reactions in the liver. Hepatic enzymes chemically modify a variety of substituents on drug molecules, thereby either rendering the drug inactive or facilitating their elimination. An exception are prodrugs, which are inactive and must be metabolized into their active form. Regardless of where drug metabolism occurs, the general role of metabolism is to increase the hydrophilicity of the drug, making it more easily excreted in the urine. Half-life. Some drugs enter and leave the body quickly, while other drugs remain active in the body for long periods of time. The standard method of describing how long it takes to metabolize and excrete a drug is the elimination of half-life, or the time it takes the body to remove 50% of the remaining drug from the body. Half-life is the determined amount of time required to reach a steady state and the dosage interval. Once absorption and distribution are complete, the half-life is the time required for plasma concentrations to decrease by 1/2. Half-life depends on the values of clearance and volume distribution. For most drugs, it takes 5 half-lives to reach steady state in the plasma. The half-life helps determine the following: the dosage, the frequency, and the duration. The dosage is how much of the medicine needs to be administered. The frequency is how often the drug should be taken, and the duration is how long the drug will remain in the body in significant amounts. If a medication with a long half-life is taken too frequently, the patient may experience toxicity from the drug due to high drug concentration levels in the blood. On the other hand, a drug with a long half-life may need to be taken less frequently, such as once per day. For a drug with a short half-life, such as many antibiotics, the patient must take it frequent doses to maintain the correct level of the drug in the blood. A patient with a liver or kidney dysfunction may not properly metabolize or excrete a drug, resulting in higher doses circulating for longer periods of time and potentially producing symptoms of an overdose. Drug elimination. The inactive chemicals or chemical byproducts and waste, also known as metabolites, are broken down through the process of metabolism, are removed from the body through the process of excretion. The kidneys are the most important organ for excreting water-soluble drugs and their metabolites into the urine. Many orally administered drugs are incompletely absorbed from the upper GI tract, and the residual drug is eliminated by fecal excretion. Some chemicals are excreted from the lungs through breathing or lost through the evaporation of the skin during sweating. Very small amounts of medication may also be excreted in tears or even the milk of a mother when breastfeeding. A patient who has poorly functioning kidneys may be unable to excrete metabolites in the urine. Thus, they may accumulate in the body and become toxic. For example, people with predisposition for kidney dysfunction should avoid nonsteroidal anti-inflammatory drugs, even for short-term use, because NSAIDs induce constriction of the afferent arteriole that further diminish kidney function. Clearance is the most important pharmacokinetic concept because it determines the steady-state concentration for a given dosage rate. Physiologically, clearance is determined by blood flow to the organ that metabolizes or eliminates the drug and the efficiency of that organ in extracting the drug from the bloodstream. Clearance is defined as the volume of plasma that is cleared or removed from the drug per unit time. This quantity reflects the rate of drug elimination divided by the plasma concentrate. For most people, the rate of metabolism and excretion are the same. Athletic trainers must understand the potential complications of medication use secondary to exercise. Currently, little research exists on the effects of exercise on most medications. However, some studies indicate that there is no substantial effect on exercise on medications administered orally. There are some exceptions to this area, including the antibiotic doxycycline and certain beta blockers such as atenolol and propanol that have demonstrated an increase in serum concentration after exercise. Digoxin and warfarin are also affected by exercise, but they are not generally used by competitive athletes. In summary, it is important to have a basic understanding of pharmacokinetics. Pharmacokinetics can be used to enhance the care of our athletes and can help us to avoid unintended consequences. It is important to understand the pharmacokinetic process of absorption, distribution, metabolism, and excretion, also known as ADME. After this chapter, you should understand the dosing, clearance, and plasma concentration. And understanding pharmacokinetics helps to enable athletic trainers to monitor doses and engage with prescribers as needed.